there aren't any universities that are set up to think with this kind of agenda. And it's one of the catchwords is a preferential option for the poor, and another is global health equity.
Yeah.
That every person on earth deserves high quality health care.
We have to fund appropriately, but then leave the experts to do the work, because there's going to be beneficials not only for Tamaris, but maybe for other financial partners or maybe the nation.
So I think most of civil society in Indonesia that works at national level and subnational level, we are used to have a relationship with the traditional donor that is no longer with us now. I think that changed the whole global health architecture funding landscape. And now people are saying, okay, go to the region and also go to your national counterparts.
Each sector was tired. The public sector tired of over-promising from politicians, but with limited fiscal room, right? The private sector is tired of making profit with the cost of ecosystem, with the cost of ecology. And the civil society is also having limited funding, but having so much aspiration. So they conclude that we cannot run on our own. We have to work together.
Halo teman CISDI, selamat datang kembali di episode yang terbaru dari podcast CISDI atau Siniar CISDI Setara Talks. Saya Diah Saminarsih kembali hadir di sini bersama beberapa narasumber untuk mendiskusikan topik yang amat sangat penting untuk didengar oleh teman-teman yang selama ini setia mengikuti Siniar Setara Talks. Pada episode kali ini agak sedikit spesial karena kita kedatangan tamu yang jauh datangnya dari luar Indonesia, dan episode Setara Talks kali ini akan berlangsung dalam bahasa Inggris karena tamunya tamu jauh dan berbicaranya dalam bahasa Inggris. Tapi ada dua narasumber lain yang bersama-sama dengan saya di sini juga akan mendiskusikan sebuah topik yang penting ini, dan kita akan sama-sama melihat, mendengarkan, menyimak beberapa pandangan tentang primary health care atau layanan kesehatan primer, khususnya tentang sebuah inisiatif baru yang diluncurkan atas kerjasama dari CISDI, Universitas Harkat Negeri, Tamaris, Hidro, dan Harvard Medical School, di mana kita akan membicarakan berbagai hal di dalamnya. Misalnya, kenapa kolaborasi lintas negara itu penting di masa-masa yang seperti sekarang. Kenapa private sector atau sektor swasta mau masuk ke dalam isu kesehatan yang biasanya dianggap tidak ramah untuk private sector. Bagaimana peran universitas dan pendidikan, bagaimana peran masyarakat sipil di dalamnya. Jadi topiknya sangat seru, dan saya pada kali ini ditemani oleh narasumber ahli, yaitu Bapak Sudirman Said, Rector Universitas Harkat Negeri, Bapak Mohammad Syahrial, CEO dari Tamaris Hidro, dan Dean David Golan dari Harvard Medical School. So right now we are going to talk about why you come, Dean Golan, from all the way from Boston to collaborate with all Indonesian organizations, CISDI, Universitas Harkat Negeri, and Tamaris Hidro in primary healthcare. In what you have a team with you, Global Primary Healthcare Initiatives. Can you explore more about that? And then I will move my questions to Pak Sudirman and Pak Syahrial.
Great. Well, thank you very much for the invitation to come to Indonesia and for the invitation to participate in this wonderful podcast for education and improvement of society. Harvard Medical School has a mission statement, and the mission statement for many years involved the alleviation of suffering caused by disease. And most of our research was focused on disease-based research after diseases were diagnosed and how to treat patients, and we're very well known for that. Several years ago, we realized that that was not encompassing enough, and the mission statement was changed, and now it talks about alleviating suffering and improving health and well-being for all. And global primary health care is an essential element of health and well-being for all. And one of the corollaries of that is that people need to receive care close to where they live and where they work. It's often said that 90% of health needs can be managed effectively in the primary care setting. You don't need a big hospital setting in order to do it, and in fact there are many disadvantages to going too fast to a hospital-based system of care. And yet, in both high-resource settings and low-resource settings, care has traditionally been centered at hospitals, which is more expensive and often less effective. As a global society, we're spending more than we need to without getting the health outcomes we expect or need, and this is especially true in the United States, as I'm sure you've all read. In most places in the world, the percentage of health expenditure as a percentage of GDP is exponentially climbing, and this is not sustainable either. So we feel that it's critical to move from hospital-centered care to people-centered care and community-centered care, and that's what global primary health care is all about. That's what your goal is here in Indonesia, and we're delighted to be thinking with you about how to make that happen.
When you first were notified or were being updated or received the report that, oh, guess what, we're going to Indonesia. How did you feel about it? Is it something that you have in mind, that Indonesia has always been on that list that you have of countries that you would like to be in partnership with, or were you surprised? What did you feel?
Well, in my role as Dean for Research Initiatives and Global Programs, I've been to many different places in the world. There are always local challenges and local considerations, but as you know, one of my friends and colleagues, Paul Farmer, used to say, global health is everywhere, and people everywhere on the globe need high-quality health care delivered at a place where they can receive it at the right time, the right place, by the right people. We're very fortunate to have had a group that my colleagues who were here in the audience, Dr. David Duong and Bethany Holt and others, have been working in Southeast Asia for quite some time, especially in Vietnam and now in Thailand and the Philippines and other countries as well. And so through them, I have learned quite a bit about Southeast Asia and some of the health needs and the advantages and the challenges. I also spent a fair amount of time in China some years ago. And so Indonesia is a natural extension of our interests in this region. And over the last couple of months, through you and many others, I've started to learn about the challenges and the opportunities here. And I'm very excited to be here working with you.
Thank you. I will move to Pak Sudirman now, Pak. In your role as, well, it's a relatively new role that you just stepped into as the president of Universitas Harkat Negeri in Tegal, Pak. I want to ask you first about feelings also. When you learn, I reported to you and you know, proposed that let's go with Harvard, let's go as Harvard. What were you feeling, Pak?
First of all, I would like to welcome Dean David Golan to Indonesia, and it's such an honor for me to be here with you. So when you ask about the feeling, this is kind of the big age, right? And then we are small age in the girl.
Harvard and Harkat.
Harvard and Harkat. So, but nevertheless, this is a really great opportunity to learn, to get so much lesson from such a great institution that's having long experience.
Yeah.
And I think it is honor for us, and the fact that you are willing to share your resources, share your knowledge, share your experience to small institution in small city. I think this is going to be a challenge for us, but it is also an opportunity. And again, we really thank you for your willingness to work together with us.
Dean Golan mentioned something about Harvard mission, the mission statement that got corrected over the years or revised, revamped over the years. Universitas Harkat Negeri as a new, relatively new education institution. The mission is actually aligned with a world-renowned global institution in education, Pak.
Yeah.
Where do you see the alignment of those two missions? Because you mentioned one is located in Tegal and it's new, and then one it's located in the U.S. in the more advanced system.
I remember the conversation with another David in Geneva a couple of months ago, and I explained that this university is just established, renewally established, but he was kind of challenged that he said, well, we have the similar project or initiative such as what David explained just now. So what we are thinking is if we could provide the richness of local content, of the local wisdom or local challenges, I think then we match with the global experience. I think both sides will learn together, and then we need to have best practice from around the world.
Yeah.
On the other hand, the local content will be also complete or giving addition to the knowledge from other part of the world.
Yeah. So the starting point of communities actually are the same with your strategic vision and the university's strategic vision. Now, as we move to the other party in the room, where these two are usual suspects, right? Education, and then usually the natural collaboration will be with another university, another research institute, civil society, that sort of form a more natural or expected. And then as a surprise comes in a private sector, and even more of a surprise, a private sector from non-health angle, right? Pak Syahrial, if you can talk more about your sector, your side of the story, but also perhaps unpack a bit more why us? Why CISDI? Why with CISDI and UHN and Harvard? Where do you see yourself in that equation, Pak?
Okay. Thank you, Diah, for having me. And then also, nice to see Dean Golan and my mentor, Pak Sudirman Said. Well, back in 2011, when we started Tamaris Hidro, surprisingly, our vision is actually to participate in making the nation healthy. That is back in 2011. That's our vision. Our mission is, how do we do that, right? So we have to be part in a renewable energy movement. So we create mini hydropower plants, where starting in a very boondock area, which is in Lombok Island. It's north of Lombok, where there was no road at that time. We built about 9 kilometers of road just to get to our site. And that, for me, it as an infrastructure game. And then we had to talk to people over there. We have to communicate with the community, right? Because they are very surprised, that the river can actually produce electricity, right? Because there was no electricity at that time. They have battery charges, using the battery. But now, not now, but 7-8 years later after the construction, you can see the place is just booming, right? They can export commodities. They have schools. They have clinics, and now they have one of large hospitals in the city. So we see that as a progress. You have to start with infrastructure, right? So, and then 14 years later, I met Ibu Diah at the Universitas Harkat Negeri. At that time was is a vocational school, right? But I still cannot believe myself now sitting with you guys. But anyway, it was a very critical moment, very emotional moment that hey, I have to start something, We have to build something, So that's how it is now, right?
Yeah. So it's the usual suspects and the non-usual suspect form a collaboration with a big vision for communities' health, to hear what they need, to design models based from what they need and the challenges they faced in Golan. So what I'm describing is actually what we call, with the Lancet Commission that the under David chair and also Dr. David Duong and Dr. Bethany Holt chair. We talk about people-centered care a lot, and I think that should be the heart of primary health care. I would like to, I'm sure if I ask you a question about primary health care, it's, outside of your head. It's like automatic almost when we talk about primary health care. And I will visit that later and talk about your experience with Partners in Health, where I believe is the root of your collaboration, global collaborations. But I believe primary health care is a new topic for Pak Sudirman and also for Pak Syahrial. It's
for
definitely
the audience as well.
Yeah, and for all of the audience, not everything is easily explainable in primary health care. So if I ask you, Dean Golan, to explain primary health care as a whole in a language where it's not too scientific, not too textbook, like more easier to digest. So collaborations like this can be replicated by other people as well. What will you say about primary health care?
Yeah, well, primary health care in many ways goes back to the roots of how medicine used to be practiced when physicians were generalists. They could try to diagnose any condition that a patient had, all kinds of treatments. In many cases, physicians used whatever means of transportation was available, walking, horses, eventually cars, and traveled to people's homes where people were, and whatever the patients were experiencing, they would talk to the doctor, and the doctor would spend a lot of time with them trying to figure out what was going on and then develop a treatment plan, and then follow up with them on their travels, later on, a week later or several days later, whatever the time course should be. Medicine has gotten away from that model, especially in high resource areas, but I think in some ways, even in low resource areas, they've tried to copy the high resource areas where care has become more hospital-based, more specialist-based, more treating one symptom and going into what's wrong with your kidney or what's wrong with your liver or your lung, and kind of not really thinking about the whole patient and what's going on socially, what's going on in terms of determinants of health, environmental factors, family factors, other kinds of dynamics. And I think primary health care is the modern answer to that issue, but it's going back to a very old tradition where physicians are again looking at the patient as a whole person and trying to understand what is going on with this person. Why is this particular symptom or ailment being manifested in this particular way, and what can we do to treat it? And that is a change in paradigm. It means that we can't just rely on patients to show up at hospitals with one complaint, but we're now trying to deal with the whole patient. So I think it's a much healthier way to think about medicine, but in order to really practice it effectively, we have to train doctors, nurses, community health workers, other healthcare providers in how to think about the whole patient again, and referring appropriately to specialists when specialist care is needed, but much more of going back to a one-on-one provider-patient interaction and dealing with the whole patient.
As I listen to you, I see a paradox, because at this point in our lives, there is the pressure to make everything quick and delivered fast, while actually what primary health care needs, actually you were just saying, if I understand you correctly, it's going back to what each might need, where it is perhaps not as fast. How do you see that in navigating the current world, where, okay, what will be the care for the masses versus what will be the care for a community, not necessarily the same with other communities' needs, perhaps. How do you navigate that with your not challenges, but experience from different countries that you have been in?
Yeah, I think, countries like the United States have a lot to learn from the way healthcare is being practiced in some areas that are much less well resourced. And one of the big innovations are to draw in additional professionals who are not necessarily physicians or even highly trained nurses, such as community health workers and others, who can spend the time with the patient and help to deliver the care, can work with the physicians who have less time, can work with the nurses. Okay. So it really takes a team. It's a team approach. And again, that's another area where we need to retrain people in terms of health professional education and training people to work more in teams.
So approaching it with a team perspective rather than a one-on-one session or clinical practice.
Right, and putting the patient at the center of the care.
Okay, that's the most important thing.
Yeah.
Pak Sudirman, based on what Dean Golan just said, I see that there is a huge call or expectation from universities to be able to also serve serve communities, not just, and beating the whole stigma of, universities are ivory towers. being out there, unreachable, but now it's actually universities within communities serving what communities require or what they actually are saying. How do you see Universitas Harkat Negeri in this new change landscape, Pak? Because it's different, right? It's not the traditional approach of a university.
If I can look at primary Harkat as an institution, then every institution needs three elements. Number one is people. Number two is structure. Number three is culture. From the culture, we can expect there is habit, there is experience, there is vast knowledge of people who have done this. From the structure, we can expect the way of working, the structure of organization, the technology and everything. From the people, we can look at the knowledge, attitude and behavior. So I think what university can be is kind of the hub of everything we can gather, and then by that point of view, then we can contribute to the starting from developing policy, implementing the policy. But I think the most important thing is the campuses or the universities cannot be in distance with the community. We have to work together with the community. And I think the strategic point that UHN can serve is we are part of the rural community, so we can be as close as possible with the community.
Yeah.
And like Dean Golan said that the less technical education, like helper, caregiver, we can produce more kind of expertise, and then to expand the existences of the primary health care centers.
Yeah. Okay. Dean Golan, there are so strong similarities between the big H and the little h, like what Pak Sudirman just said. I keep on going back to the University of Global Health Equity,
Yes.
the similarities between the two. I talked with Pak Sudirman about the plan for collaboration for primary healthcare, that context of the University of Global Health Equity in Rwanda kept coming up because of the similarities of geographic and demographics of both places, where UGHG is in and where UHN is in. Why is it that I see many universities here and many hospitals in Jakarta and also in the US that came up in the hardest or hard to reach area, or the poorest area, or the marginally challenged in health and also in social economics? Why? What is the science behind that thinking, Dean Golan, if you can shed some light on that?
Yeah. Well, I think that the tradition in the U.S. Really came from the European tradition of education and also healthcare and training. And there, I think the universities are in the big cities, and the teaching hospitals are in the big cities, and the research institutes are in the big cities. And it was more or less expected that people who had health issues would somehow be able to travel to the
Far,
big cities,
yeah, exactly.
and go long distances. And that didn't work out so well, and many people were left behind. And I referred to Paul Farmer earlier. I'll bring him up again. He was one of the co-founders of Partners in Health, an absolutely brilliant medical anthropologist and infectious disease physician who preferentially worked in the poorest areas of the world, because he felt that was where the need was the greatest and he could have the greatest impact. And Partners in Health started in Haiti, in rural Haiti, in a village that had no electricity, no running water, no green, no gardens or anything. Paul visited and said, "This is where I'm going to start my clinic." And they said, "How are you going to do it?" And he said, "Well, we're not going to do healthcare first. We're going to bring electricity, and we're going to bring water, and we're going to bring roads, and we're going to improve the environment." And that was in Kange, in the Central Plateau, in Haiti. And that's what happened. And Partners in Health has multiple sites in Haiti, and then he took an interest in Africa and did a lot of work in Rwanda. Again, same thing, choosing places, no electricity, no running water, built it up. And along the way, as he developed his vision, he said, there aren't any universities that are set up to think with this kind of agenda. And it's one of the catchwords is a preferential option for the poor, and another is global health equity. That every person on earth deserves high quality health care. And so his dream was to start a university of global health equity, and he was viewed as a dreamer, and this is not practical, and how could we ever possibly make that happen? And with the help of very dedicated donors and the Partners in Health infrastructure, which had now been built up quite a bit, and many helpers. Many of my colleagues at Harvard have been involved in this and other places around the world. They set up the University of Global Health Equity, not in a big city, not in Kigali, but in Butaro, a very remote area in Rwanda. And it's a very interesting model. They have a master's degree in global health equity. It's the first one in the world. And whatever other degree you do at that university, you have to do a master's in global health equity along with it. And they started that master's program before they started a medical school or a nursing school or a pharmacy school. And now it's being built up, but with the global health equity agenda. And it's a very powerful model. I will say, when I heard that in Indonesia you were interested in this model, I actually got chills thinking what Paul Farmer would have thought. He tragically passed away several years ago.
I should say that we found Paul Farmer now.
Yeah, I was going to go to you because Dean Golan set up a whole nice plane for me to ask many questions.
We experience on more than 10 sites like that, right? Where there's no access of electricity, no internet. Every time we enter the site, we have to at least 3 months without any communication. There's no gadgets, no handphone, everything, right? So, but we make it happen is that, because our contract with the community, with the power company, the state-owned power company, it's like 15 to 20 years, right? This is not a transaction, right?
Yeah.
This is a relationship. Right? So this is the relationship we have to build with the community, right? Because they safeguard us, they care about us, they build it, they were the workers, they're right now the employees, and they're setting up example to the other families. Things can be done, and that's what the relationship can go on. You have to be healthy, right? Because then and it frustrated me if I see my employee, something, got injured because of, like broken bones, and they have to go about an hour and a half, just get treatment, right? and then the son or the daughter that got sick, and they have to find a doctor within probably 45 minutes, you know, and then sometimes they arrive in a small clinic and there's no doctor, right?
Yeah.
So that place is Golan. We have 15 of them. So, you know, I think we should maximize, optimize that, you know, in a way that that we have to, we cannot extract value, you know, from that community. We have to add value on the community itself. That's our goal, basically.
Wonderful.
But through all that, you face those type of challenges throughout the how many years since 2012 until now, and you have, I bet, you have never heard of a proposal for a research institute to solve your problems, right?
Well,
now I'm asking about feelings. How do you feel when you receive that?
well, okay, don't get me wrong. Before I started this business, we did research for at least 2 years, you know, to find the right spots to develop something like so. So the knowledge that I don't have, I don't know anything about health. I don't know anything about medical, right? So I have to trust the researchers to do the work, right? And they have to come up with a viable research, workable research, right? And I have to be patient, right? So because
Thank you.
your research is going to be like 18 or 24 months, right?
Yeah.
And it's one more power plant I can build, right? So I really hope that, I mean, our participation is, I am fortunate that we can give at least direction, but I have to sit on the back seat, you know. I cannot drive this field. You know, we have to fund appropriately, but then leave the experts to do the work, right? Because there's going to be beneficials not only for Tamaris, but maybe for other financials partners or maybe the nation, right? And it excites me. You know, there are 2 H now we have, right?
The big one and the small one, or
as
equally big?
As a drivers. Will be equally big.
Equally big.
In Indonesia, at least. So I think that is our hope, Ibu Diah. Thank you.
Thank you. So, yes.
If I could just
of course.
follow on with that, I mean, what you're saying is so important because, you know, many non-governmental organizations, NGOs, have their own ways of doing things and come in with a set idea of what needs to happen and come in and sort of impose that view on the local community. And often it doesn't work and it's not sustainable. And so one of the keys is, I mean, you may say you're in the back seat, but at least you're in the car. And, you know, the first thing that has to be done is a needs assessment, which is a collaborative effort that involves all of the stakeholders, the power company, the finances, the university, and most importantly, the community and the people. And when a collaborative development plan for the research and for what will happen can come into being, then everyone has a stake in how it's implemented, and everyone can participate in the implementation plan. And this, I think, is a key to what you're planning, and we heartily endorse that model because that's the one that can lead to sustainability and success.
Yeah, I think also co-creation comes from different angles. Co-creation between the founders, the visionaries, and co-creation with communities. I think both, and also co-creation with the local governments, the national governments, the funders. I think those equally need co-creation at all of those levels. That is what. That's why I think Phil is a bit different, because we take time in co-creating our model and all that. And you know, Pak Syahrial, thank you for giving us the trust and the opportunity and the time to do it.
Well,
Because
it's a culture gap, but
It's a
because but
culture gap between, of course, between private
it's
sector
good to
and
learn,
yeah,
right?
yeah.
Something new, something excites us. To
Yeah.
do.
And
Can I-
something unique will come up.
Oh yeah,
Something,
for
yeah,
sure.
yeah.
Yeah.
Can
Yeah,
I, one more thing to make both of the gentlemen make comfortable, because the fact I was born in that area, and that area by ranking is one of the poorest district or region in Central Java. So anything you could add, whether it is resources, whether it is knowledge, whether it is expertise, I think the progress will be significant. So I think this is kind of the right path
Yeah.
to do something, and then if we could successfully done this, then we can copy, we can multiply at least
Yes.
through his network
Yes.
in couple project sites.
And let me just say that there will be lessons that can be learned in the much more developed areas of Indonesia, because I don't know that much about your country yet, but my guess is that healthcare is not perfect anywhere
Yeah.
in the country. It's
Yeah.
not really perfect anywhere in the world.
Yeah.
And there is a lot that can be learned from what will happen in Tegal and other areas like that, that can then be brought into the big cities and improve healthcare
Yeah.
really throughout the country.
How do you see the closing of the gap of knowledge, in Golan? Because you come from a very sophisticated, science-backed knowledge of primary healthcare, of global collaborations, of what universities should be or should not be, what communities should deliver, or what should we hear when we do co-creation with communities. What should we hear from them, actually? You have all that skills and knowledge and expertise backed by science, while from here, perhaps our horizon is not that big yet, and we have a lot of local context and uniqueness that we need to share with you, and to bring our own expertise of what we know, of course, and to build a partnership among equals. How do you see that in the changing landscape of global health, where now you have to perhaps listen and acknowledge expertise from local institutions, and perhaps not as much before than now? How do you envision the bridge between those two?
Yeah, I think the right response is that what is important is to make sure that the data are collected properly and analyzed properly, and rigorous research methods are used to figure out what the right solutions are. It's not for a university like Harvard to come in and say, this is the solution for you, but when it really isn't the solution for you. But what we can do is help by saying, well, if you're doing a study and you're doing a needs assessment, these are the things you have to look at in the needs assessment. These are the kinds of stakeholders that you need to hear from, and this is the way that you need to think about the data that you're collected, and these are the research methods that can be used for doing proper studies that allow you to get reliable evidence that can then be used to drive policy and to make change and to implement.
Okay.
So I think we can help in areas like methods and analysis, but you will be the ones who will be the experts in what's going on locally, and we need to hear that from you and then work together. And then the other part of it, and we do a lot of this, is capacity building in terms of training local people to be able to do this on their own, so that as conditions evolve, then you become more and more independent in being able to drive excellence forward move the country forward.
Thank you. Yeah, and I have to say that in the past few months, the collaboration between the Harvard team and with CISDI team and with UHN team has been going exactly like what you said. I think this is also a collaboration where we know we have a partner with us, not to tell us what to do, but to think together. And I think that is, from civil society perspective, that is really a treasure. For us to have, and like what you said, Pak Iyal, the relationship to be built in the future. But also we have to acknowledge, I think, that the world is not the same anymore as when Paul Farmer went to Rwanda, as when perhaps the both of you started the university. I would like to ask your perspective first, Pak Iyal. When, as a private sector, when you go into a collaboration like what you are going with the university and also with Phil, with the Primary Healthcare Impact Lab, what is your expectation actually? How long, how short, how quick? How much can you tolerate? Because, no, I'm asking from a civil society person who we are used to, I think most of civil society in Indonesia that works at national level and subnational level, we are used to have a relationship with the traditional donor that is no longer with us now. I think that changed the whole global health architecture funding landscape. And now people are saying, okay, go to the region and also go to your national counterparts. Private sector becomes one of the natural choice for that. But I also acknowledge that the relationship between private sector and civil society and research and universities have not always been smooth. And actually it's a big of always cannot bridge the communication gap, cannot bridge the expectation gap. And what would you like to see from this?
Okay. I might be lying if I said I do not want to have any financial return out of it, right? Because, as private sectors, I agree with Dean Golan. Sometimes we have too much KPI, governance here, governance there. And actually, there are three things. If you want to collaborate, from the experience that I had. First, about stability. Right? We know exactly what we want to do. Clear path, right? And then also, from there, on a process, we build trust. So when we have stability and we have trust, and now in these 15, 16 areas, we have social license, where we already built there over the years, right? So you can leverage us on that, right? So that's why it is of course, it's a long-term game, right? It takes us 9 years, Dean Golan, to be profitable, right? We keep pumping money here, but we believe in the mission, right? So that the trust word itself, it's very important in any collaboration. So if you don't have trust, right? You don't feel comfortable. There's no stability within us. So it's no. That collaboration is just going to fall apart, right?
Yeah.
So there are so many private sectors that want to engage, right? So, but I really have to know my partners, right? At the end of the day, right? Because if money is the only target they want, it might not be within our vision, right? But if they want to do something much more contribution for their life, then let's do it, right? I mean, looking at your figures, life expectancy is only 71 years old. I still have 11 years, and after that, bye-bye, right? So,
Not necessarily.
what I'm saying is that it's Indonesian average.
You're sitting next to the dean of
I was surprised.
Harkat.
71, and then 9 years, I have to be not healthy before reaching 71.
But you can exceed that life
exactly
expectancy.
right. So that's what we want to do with our people, right? So that they don't have to get sick for 9 years,
Yes.
right? So we have to start with private companies and universities that have the same vision, right? It's hard, and sometimes the universe guide you somehow. I don't know, as long as you have the good intention to do, and I think somehow they will collaborate each other. I believe so.
Can I make two
Yeah, of
points
course.
about
Yeah.
this as it relates to Harvard? One is that Harvard University and Harvard Medical School in particular, in some decades ago, were known really only as premier research institutes, and people viewed it a little bit as an ivory tower with not much connection to society and problems of society. In the time that I've been at the medical school, which is now almost 40 years, there's been a shift, I think driven by the students actually, who want to be engaged in the world. They're not. Some say I want to pursue this, very detailed problem and take it as far as it goes, and I don't really care about the rest of things. But most students want to help people and help communities and help society and make a societal contribution. And that is now translating into the junior faculty who come to start their own laboratories and their own research. They want to make a difference in the real world.
Yeah.
And it's very much the belief of our current dean, George Daly, who came in and said, if we stay in ivory tower, we're just going to go off and society isn't going to support us anymore. And already higher education is under a lot of threat.
Yeah.
So we very much believe that these problems in the world are things that universities have a great contribution to make, and that this is actually part of our mission going forward. The other point I want to make is that we're now thinking at the medical school in particular, also at the university, about how we can engage with the private sector much more productively. Because these problems need to bring in expertise from many different sectors in order to be solved. And one thing that we have realized is when we deal with companies, if all we do is go to the company and say, you have all this money, give us the money and we'll do good things with it, it doesn't work.
Yeah.
What works is when we say we have a certain area of expertise, we know that you have a certain area of expertise. Let's get your scientists and engineers collaborating with our scientists and engineers. We'll solve the problem together. And there may be some funding that's required in order to make that happen, but the primary reason for collaboration is because of the problem and attacking the problem.
Alignment and similar mission.
Absolutely.
Yeah. Yeah. Pak Dirman.
Yes.
I'm going to ask you a question because you are a man of many facets, Pak. Yes, you are a rector of the president of the Universitas Harkat Negeri, but also the public knows that you are not only that. I will not mention what else, but at least for one, you were the ex-minister of energy and resources. I know you have big aspirations for Indonesia. You have a dream of your own to see what Indonesia should look like or hope to look like. And how do you see that bigger dream and this dream that we have envisioned together and collaborate in with the Primary Healthcare Impact Lab?
Just before that question, I would like to thank to all of you from Harvard, from Tamaris, and from CISDI, because as Diah mentioned that the collaboration among the team is very great. And for me, this is kind of opportunity. Interaction bring opportunity and make them confident. So I think with your contribution, with your support, the UHN team will be fostered. I remember in 2017, there was a big discussion in World Economic Forum. It's called as fourth sector movement, which actually driving the all sectors, public sector, private sector, and also the civil society to work together. Why this movement coming? Because each sector was tired. The public sector tired of over-promising from politicians, but with limited fiscal room, right? The private sector is tired of making profit with the cost of ecosystem, with the cost of ecology. And the civil society is also having limited funding, but having so much aspiration. So they conclude that we cannot run on our own. We have to work together. Then they come up with the concept of how can we gather these three sectors to collaborate. And I see this as a kind of embryo for developing this fourth sector movement. And if we could do this is one sector, right? And then we can multiply within the sector and also to other sectors, be it in economy, in social, in education. So I think that is what I dream about this, and I really have a very high expectation that we can do together.
Okay, thank you. I'm so sorry this has to end. It cannot be 5 hours like what you said. So thank you. It's an honor to host you in Setara Talk, all three of you, Pak Sudirman, Dean Golan, and Pak Syahrial. It's an honor for us to welcome you to Indonesia, to Jakarta, and also to welcome you to this podcast of Setara Talks. Thank you again. So, terima kasih teman-teman CISDI yang sudah menyimak. Yang tadi disampaikan adalah pembicaraan mengenai layanan kesehatan primer dan kolaborasi apa yang sudah dihasilkan dalam bentuk namanya Primary Healthcare Impact Lab, atau kita panggil dia dengan PHIL, yang sudah diluncurkan di Jakarta pada tanggal 7 Mei 2026. PHIL adalah hasil kolaborasi antara CISDI, Universitas Harkat Negeri, PT Tamaris Hidro, dengan Harvard Medical School sebagai knowledge partnernya. Kami berharap tentu sebagai 4 institusi yang bergabung dan melahirkan PHIL, kami berharap PHIL dapat memberikan dampak yang baik, yang positif untuk kesehatan masyarakat di seluruh daerah di Indonesia, bukan hanya di daerah-daerah terpencil, tapi juga di daerah padat perkotaan, di daerah yang sedang bertransformasi dari daerah pedesaan menuju perkotaan, di daerah pesisir dengan tantangannya, dan di berbagai karakter atau tipologi daerah yang kita hadapi di Indonesia. Terima kasih untuk dukungan dan kerjasamanya semua teman CISDI yang sudah ikut menyimak peluncuran PHIL pada tanggal 7 Mei 2026, dan kita akan terus bergerak di dalam lingkup layanan kesehatan primer dan public health yang mendengar apa yang diinginkan oleh komunitas dan apa yang diinginkan oleh orang per orang. Saya Diah Saminarsih pamit undur diri. Sampai jumpa di episode Setara Talks berikutnya. Salam sehat, adil, setara.